Welcome everyone. Thank you for joining us today and welcome to our session titled Ask the Pediatric Experts. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors, Alexion, Apellis, BioCrest, Bristol-Myers Squibb, Genentech, Novartis, Regeneron, Servier, and Tahoe Oncology, and also the wonderful, generous support of our patients and families. Without all of you, we would not be able to put on these programs. So thank you very much for everyone for paying it forward to help others. This is a strictly Q&A. It's your opportunity to ask the experts, so there will not be a formal presentation. So if you're online, submit your questions. We'll go between those who are here in person and questions online. So feel free to get submitting all of those tough questions for our wonderful speaker. I do ask when you're submitting questions or asking questions in person, please keep in mind that our expert speaker today cannot answer any specific questions related to your personal health care, but he will be able to answer questions, generally speaking, to be able to get you some of the answers that you need. Our specialist today is Suneet Agarwal. Dr. Agarwal is the co-program leader of the Stem Cell Transplant Center at Dana-Farber, Boston Children's Cancer, and the Blood Disorders Center. He's also an assistant professor of pediatrics at Harvard Medical School. It's my pleasure to welcome Dr. Agarwal again. Thank you for joining us.
Thanks very much, Lee. It's a pleasure to be here. And I think Dr. Pulsifer is also going to try to join at some point in time, too.
Yes. Okay. Do we have any questions in the room to get us started?
I have a question about your thoughts, expertise behind bone marrow transplant for moderate aplastic anemia and high cellularity, and if, like, the effectiveness of it, behind it, and just, yeah.
Yep, okay, thank you. So the question is about bone marrow transplantation timing, to some degree, for moderate aplastic anemia, but with the bone marrow showing high cellularity, too. So the first question that the pediatrician is always going to ask is whether or not the workup is still ongoing about what the cause could, whether there's a genetic cause that has been identifiable, how well that's been ruled out, and if one at that point is left in the state where we have moderate aplastic anemia and this degree of cellularity of unclear cause. It's about kind of diagnostic categorization, because how you would approach it would depend on those things.
Do you see a successful bone marrow transplant in those with moderate aplastic anemia and or high cellularity?
You can have a successful bone marrow transplant with moderate aplastic anemia and high cellularity. Stepping back once again, though, a lot of it depends on when there seems to be a disconnect between the degree of cellularity in the bone marrow and the degree of aplastic anemia. We do find ourselves asking the question of how much this could be bone marrow failure versus other diseases. There are other things that can end up giving low peripheral blood counts, and that they may be more in the category of attacks on the blood system rather than an intrinsic defect. Then the other question becomes about the need for the intervention, the urgency for the intervention, how well the person is being able to be maintained without any therapeutic intervention versus needing other therapies that may be causing their own toxicities as well. So I know we're speaking in generalities, of course, but I think that ultimately what it comes down to often is a very individualized assessment of what has been done to assess, and it is not uncommon to end up in an unknown category of like, this is what we're seeing. We actually haven't been able to name it, we haven't been able to put it in a particular category. And then transplant timing ultimately depends a lot on the donor availability, the type of donor that you have at your disposal. And that is colored frequently by, if it's a sibling who happens to be a match, then how sure are we about whether this process that's happening in the patient may or may not be happening in the sibling as well. So these things are taken into account, and when pushed to action, we often are trying to evaluate the best related donor versus the best unrelated donor to take that on, to consider that or to take it off the table as well too. So many dimensions to consider.
Yeah, it's so multi-layered.
Right?
Thank you.
Sure.
Anyone else have a question in the room before I go to any online?
So I was reading in a pamphlet about iron overload with a lot of blood transfusions. What is, if you ever got to that point, is there a treatment for that, or what's the route of treatment for that?
Yeah, so it's a great question. This is a question about iron overload from transfusion support, red cell transfusion support for a marrow failure disorder, what implications that has in and of itself, and then also for another intervention, perhaps like bone marrow transplant. So the two ways of thinking about it are in the status of iron overload. First, how is it being measured? And second, is it required to treat it? And so if transplant is not on the horizon, if another intervention is not on the horizon, then monitoring and intervening for iron overload in and of itself will depend to some degree on how much iron is getting loaded into organs and what the prediction is of failure of those organs. So it could be the liver, it could be the heart, and those can be measured in a variety of ways by probably the way that's okay to track but not okay to diagnose as quantitatively is a serum ferritin. And then there's other imaging methods to actually quantify more sensitively that are a little bit harder to get sometimes, and depending on the age of the child, might need sedation for an MRI, for instance. So some of those would trigger intervention. The second one would be if you're going to transplant. And so it's known that basically dropping the iron overload level in those patients is helpful sometimes in ensuring a better transplant outcome. But your question was about interventions, and there are. So there are iron chelating agents that are taken. Some of them are given underneath the skin, and some of them are taken orally. They can be effective in removing iron over time. So it takes weeks and months to actually reduce the iron level. And some of these medicines have some side effects that make it a little bit of a challenge to actually stick with them and stick through them. But that's done in collaboration with your hematologist.
And another question, with bone marrow transplant, does that kind of eliminate the iron overload, if that were to be a concern?
So it's a good question. So in the ideal scenario, depending on what the disease was that you're trying to treat, and one of the things about the disease is requiring these red cell transfusions that are causing the iron overload. If successful, the bone marrow transplant should ideally remove the need for those transfusions. So there ends up being a stopping point. But in the process of doing the bone marrow transplant, one can expect certainly that more transfusions will happen. And if there was a complication of the bone marrow transplant, even more red cell transfusions could be necessary. But yes, the point is that we will sometimes take a patient, for instance, let's say, who is iron overloaded already. If time permits, then to basically try to do some iron reduction once we've hit a certain number that's based on imaging or other tests of the body, then go to the transplant, keeping the iron overload still in mind, and then continue in the post-transplant phase to actually do things that actually remove iron further. So there are patients who actually sometimes, because now they have enough blood forming capacity, will get phlebotomy. We'll actually have blood taken out to actually remove iron stores, and it can be very effective.
Okay, thank you.
Sure.
Okay, we're going to go to a question from online. The question says, can you comment on your experience with a mismatched, unrelated donor for a pediatric patient with aplastic anemia, PNH, and a transplant? Specifically, how does the conditioning regimen change for a mismatched, unrelated donor?
So it's a good question. I'll have to clarify one thing. Is it said that in the history there was a transplant. So if in a patient who has aplastic anemia, a PNH clone, and a transplant. So it is a big difference if one is doing a second transplant versus a first transplant. Let's assume that it's not a history of a transplant and answer the question more about a mismatched unrelated donor versus a fully matched unrelated donor or sibling donor. So the regimens typically for a matched related donor for aplastic anemia will differ compared to an unrelated donor. And it's because a regimen was established that was very effective for a matched sibling donor, and unrelated donors were always considered secondary or the second line. Now, the data that's accumulating with current matching has changed. So the definition of matching has changed over the past 20 years or so. And the matching that's done for unrelated donors is a much more sophisticated one now. And so those outcomes of unrelated donors who are fully matched are starting to approximate sibling donors as well. They're not fully there, but they're actually getting pretty close in a lot of different studies for pediatric marrow failure disorders. Mismatched unrelated donors depends to some degree on what the mismatch is and the degree of mismatch. If we're talking about out of 10, we can talk about like basically matching out of 10 alleles. These days, a single allele mismatch, so 9 out of 10 donor, is still a viable unrelated donor. I think that people start to consider that more mismatches start to become more complicated for unrelated donors, and some of the considerations, depending on the patient's disease and age, come into about whether or not to use a parent, which is a haplo donor, half donor. The conditioning regimen to overcome that barrier of the mismatch, after taking several things into account about the donor and recipient, is usually more intense. More intense meaning that there may be a higher dose of chemotherapy or radiation to try to achieve the same level of engraftment. So I think the simplest answer to the question, despite all the caveats, would be that usually a regimen for a mismatch unrelated donor for aplastic anemia may be that a dose of radiation is included in a regimen otherwise, unless it can be grounded in a clinical trial that's been done that includes that donor type. And so it doesn't have to be more intense, but it may be slightly more intense, and it depends on the degree of mismatch of the unrelated donor.
Thank you so much. Does anyone have a question in the room?
Can I ask one about iron overload? Go back
Please
to
go right ahead.
you said that it's important to get to a certain number. Are you talking about ferritin?
Right, so.
And what would that number be? Like, what's your ideal level?
So actually the better measure is iron estimate in the organs based on an MRI of the liver, et cetera. And those can't be done over and over again that easily, so oftentimes people will use the ferritin as a surrogate. The problem with ferritin as a surrogate is that ferritin can fluctuate for any other number of reasons. It's an inflammatory marker as well. So I wouldn't give you a number of ferritin. It would be the type of thing that what you would do is try to tie that ferritin to what the concurrent imaging number was and see if that number could be used as a trend to show that it's actually improving, and then to re-tie that back to the imaging modality. So it can be a monitoring tool while one is getting chelated, but it should ultimately depend on what the iron overload level is by an imaging method.
Okay.
Oh, go right ahead.
Okay, so after bone marrow transplant, is GVHD always a concern for the rest of your life? And if so, if you ever develop GVHD, what is the treatment for it?
Yeah, so that's a great question about one of the things that we're trying to avoid the most, both by matching and by the way that one does a regimen, is that you've fixed one problem, you've fixed the blood disorder problem, but you've gotten another disease. So graft versus host disease, just so people know, in case people don't know online, is where the immune system of the graft, the immune system of the donor, isn't quite tolerized, isn't quite in sync with the recipient, and that immune system is attacking the recipient as well. So it's an immune mediated attack, and there's different phases of GVHD. And so your question is about, are you worried about it for life afterwards? And I can say that you can be quite reassured that it's not going to be the type of thing that comes up in year 2 if you had no GVHD before that. So a lot of it depends on what kind of GVHD did you get and how well did you do with it, determines your risk for it being an ongoing problem. The bookends would be never got GVHD, and as the months and years go by, the worry about it is gone. Essentially, it's basically not going to all of a sudden rear its head years and years later. The other side is GVHD starts day 30 after transplant with the classic acute GVHD. There's 2 different forms, acute and chronic, and that is an attack on the gut, the liver, and the skin. And that can be a risk factor for a different phase of disease called chronic graft versus host disease. In all of those cases, the treatment initially is steroids. It's basically trying to see if the person's reaction, that autoimmune reaction or their alloimmune reaction essentially is being able to be controlled using steroids. And sometimes it can be controlled with steroids and then it dies down and it's gone and it doesn't come back again. And other times you end up deciding that, well, it's happening over and over again, we need to give steroids. And then depending on whether or not the person can tolerate steroids and you can get it down into enough of a disease state, you may have to use other agents. And it can be a lifelong problem and a life-threatening problem, to be perfectly honest. So I think those are the considerations that you have around it. But it's not the type of thing that, again, pops up if things have gone well, way down the road. It's that would be very unusual.
Thank you.
Sure.
We'll go to a question online. So our next question online is, can you speak to how the onset of puberty either changes the disease itself of aplastic anemia, or is there also an impact on a patient who is still receiving cyclosporine?
So that's a good question, and it's hard to answer. I think we do see variability in people's blood counts. So you achieve a certain level of stability sometimes in treating somebody with a certain modality for aplastic anemia. And it sometimes can be after the initial phase of immunosuppressive therapy, and they're going on cyclosporine as immunosuppression. And sometimes for unknown reasons and unclear reasons, those numbers can fluctuate and the response can wane. A cause and effect around puberty is very hard to determine. There are fluctuations that coincide with puberty, so I can't comment exactly on whether or not puberty itself actually is a positive factor or a negative factor universally or uniformly, but sometimes it seems around that time that basically you can get some more fluctuations or down fluctuations in counts, but it's not an association that I know of entirely.
Great. I'm going to do one more question that is online. Do you find it is common for the platelets to be the slow responders after being treated with ATG and cyclosporine? The red counts seem to have responded better, but the platelets are dragging.
Yeah, so that's true, that can happen. I do think that there can be differences between patients in terms of what lineage was actually affected most. The things that come to mind for me sometimes are whether or not that's reflective of the process being something other than, not the platelets alone, but if you start to see lineage differences in response and one of them is responding entirely, the main question in my mind is there something else going on that's causing some suppression or problem with that other lineage? Is there some underlying disorder that's actually continuing to have an effect on that lineage, or is there some other infection or something else that's actually going on there? But I would look at it very carefully in terms of the trajectory and the time out from the actual intervention to say, well, this would have been fully expected, that this should be better by now, versus it's lagging behind the red cells. That can absolutely happen even after bone marrow transplantation, is that you can have a difference in how the different lineages respond and still need to be transfusion dependent sometimes, even after it's deemed that you've had a successful bone marrow transplant for some weeks and months after you've been discharged from the hospital.
Do we have a question in the room?
I always have questions.
Thank you.
Can you speak to failed ATG, no response from ATG, and the decision to do ATG again, specifically doing ATG and doing ATG after a failed, and is that even worth it, or is it just there's no data behind even trying it?
Yeah, so also a very good question. So if you're talking about, so you have different responses to immunosuppressive therapy for presumed aplastic anemia. Some are responses that are durable, some are initial response and then waned, and some are refractory, meaning it never really responded adequately to that. It is around that time that I think it is very important to weigh the donor options, because in the field it would be considered right now that failing once from immunosuppressive therapy, depending on what's happening with the patient and how they're doing, it would be reasonable to consider that the next step should be transplant. Right now, one of the debates in the field is whether or not, so the standards in the field right now, if you take it, and everything has to be looked at carefully for an individual situation, but if you're determined to have aplastic anemia without a genetic cause and have a match-related donor, then it would be reasonable to go upfront to transplant with a certain regimen. It's still the standard that is evolving and changing that immunosuppressive therapy is for patients who don't have a matched sibling donor. But once that has not worked, the second line to be transplant is a very reasonable one. and you're now weighing what is the suitability of the donor, the suitability of the patient in terms of how they're doing, compared to trying another round of immunosuppressive therapy. And also somewhat anecdotal about whether or not changing the ATG around is better or not. There are numbers around this, but they start to become pretty soft in terms of like what the relative response rates are. And I think in aggregate, people would say that transplant should be considered around that period of time.
Another question from the room?
After ATG, like how long would you give ATG treatment, like months after, like as far as like a pass or a fail, with the immunosuppression drugs?
So that's a good question too. So we generally expect the response to happen within 2 to 3 months of actually having the ATG and being on cyclosporin, presumably still at similar doses. If there's some hint of a response, and depending on what the options are, seeing what it is within 6 months. After that, it would be very unusual to actually expect there to be now a response from that initial course of therapy, and you should be deemed refractory at that point and thinking about the next steps.
I'll take a question from here. The question is, we're newly diagnosed with aplastic anemia and trying to make treatment decisions. We've been presented ATG, or we can look at a haploid match transplant. How does a family decide which option would be best? Second part to that is, if we go with the ATG, can we still go to transplant? And the other question to that is, if we go ATG then transplant, does that lessen the likelihood of success?
Okay, so good questions and active ones in the field. So we already spoke about the conventional path for a patient presenting with new aplastic anemia and the intervention, assuming that it needs to be done soon and right away, in the absence of having a matched sibling donor. So then there's a consideration of what's the standard you could consider in the United States of doing immunosuppressive therapy next. There are active trials going on, including pediatrics, of whether or not one could do a haplo transplant, meaning a half-match transplant, usually from a parent, sometimes from a sibling, where it's not 10 out of 10, it's essentially 5 out of 10, maybe a little bit better just by chance, but you've essentially gotten one chromosome obligatorily from one parent and one chromosome from another parent. And so the actual answer is that there is not an answer to that question about haplo transplant as an upfront modality for pediatric patients. That is part of a trial that's actually going on right now. So I would be hesitant to consider doing that except in the context of the trial. There's another trial going on right now, which with data that was there before in the United States, of comparing upfront unrelated donor transplant to ATG. And that is a trial that is being randomized, meaning that a patient was enrolling in it, they would allow themselves to have the choice made for them, so that ultimately one could compare the decision. That's generally the best practice for a clinical trial to answer a question that is one of these approaches better than the other. So those are very good questions, but I think I can say that it would not be the standard for a child to get an upfront haplo transplant as opposed to ATG. And if there's a trial available, that is a reasonable thing for the family to consider, and the risks and benefits described by the investigator who's treating. The second question was, if one does immunosuppressive therapy first, is it okay to go to transplant? Is that
Yes.
or is transplant viable? Yes. So that is the actual path in the United States, is that typically if you have not had a durable response from immunosuppressive therapy, then what one would move to next or consider strongly is transplant. What are the downsides? So what do we see that actually we don't like to see down the road is if there hasn't been a very good response and the person has accumulated infections or infectious complications, that can make transplant more complicated. Transfusions, red cell transfusions, iron overload as a complication. Cyclosporin use for a prolonged period of time and this, I'm not trying to say things that happen to every patient, but the things that are on our mind is, how did the cyclosporin affect the kidneys over that period of time, and how are the kidneys doing as we're heading towards transplant? And then finally, the number of transfusions accumulated over time. If there's been just transfusions going the whole time, you do start to count them. You do start to think, how many of these has a person had? And because there is the possibility of what's called allosensitization, meaning that the person is developing some immunity against donors in general. So these are not absolutes. You do what you have to do, you get the transfusions that you need to get, you get the supportive care that you need to get, but it is on our mind a little bit that after getting a course of immunosuppressive therapy, there should be some deliberate movement towards other therapies because there are some toxicities potentially being accumulated over time. And then the final question is, the final question of that three-part question was about if one were to go to transplant after the ATG.
What's the rate of success?
Rate of-
Does having
right.
ATG impact the
So,
success of a
right.
treatment?
So I think I answered that essentially in
I
that,
think you did,
because
yeah.
it wasn't about the ATG, it was more about the course of immunosuppressive therapy and how
Yes.
long you wait. Okay, so yeah, that's.
Yes. Any questions from her? Go ahead.
Isn't ATG what's used pre-transplant?
It can be in some regimens as well. So ATG is anti-thymocyte globulin. So just so you know what it is, it's basically trying to get rid of the specific immune cells, T cells, essentially is what you're trying to get rid of. So T cells protect you from viral infections. They are the memory that your body has when you get vaccinations against infections. These agents were developed primarily to help with transplant and also to treat graft versus host disease. We can think about it that way because T cells also cause graft versus host disease. So ATG is a way of immunosuppressing. It can be used in the context of trying to suppress the immune system for aplastic anemia. It can also be used to suppress the immune system to receive a graft during transplant. It can also be used, depending on how it's timed, to consider that you're reducing the chances of graft versus host disease because you're getting rid of some of the T cells in the donor. And the downside of that then is that you might actually have less immunity and be more susceptible to infection. And these are somewhat crude modalities too. This is essentially horse versus rabbit means we basically made antibodies against human T cells in a horse or in a rabbit and used their serum to attack those cells in the recipient. But they've been proven ineffective, and using one in the aplastic anemia phase doesn't preclude using it in that bone marrow transplant phase.
We have a question online, and the question reads, for a mismatched, unrelated donor transplant, what are the pros and cons of the stem cell source either being bone marrow versus peripheral blood?
Okay, that's a very good question too, and one we don't engage, I think, as much, although it comes up in pediatrics. So just so everyone's on the same page, so bone marrow, so stem cell sources. So one is bone marrow, essentially is the donor is going through the procedure that you're probably familiar with of having a bone marrow aspirate done, but here now lots of bone marrow is being taken from the donor. And that's going to collectively be the product that's actually given to the recipient as if it's a blood transfusion. So the bone marrow transplant, just in case it was a concern, is not putting it into the bone of the recipient. It actually, and the stem cells in that product will go and find their way into the bone marrow and do the thing they need to do. Peripheral blood stem cells are collected from the donor, so this is more about the donor, are collected from the donor by mobilizing their blood stem cells that are usually in the bone marrow and making a higher proportion of them in the blood. And then taking them by, the patient has 2 IVs, for instance, and a machine can actually take the stem cells and other white cells from basically having the blood circulated through that machine. So you have 2 product sources, just to name what they are. Both of them are suitable graft sources. The peripheral blood stem cells have the advantage of probably engrafting faster because they have more T cells, but they cause more graft versus host disease. They also have, in the cases of cancer, probably a better anti-leukemia effect. So if you're trying to use the graft, which is part of transplant, to actually attack the leukemia that you have, there's probably some advantages there. Bone marrow has less graft versus host disease because there are less T cells. And also is a perfectly acceptable graft source, especially in children when you're thinking about doses and engraftment. So the preference in and there's been a good study comparing side by side the two agents, and generally speaking, it was for malignant disease in adults. And because their overall survival was the same, but there was less graft versus host disease with the bone marrow. So when we're thinking about a non-malignant disease, a non-cancer, non-leukemia, like aplastic anemia, we have a strong preference for bone marrow in pediatrics. But you can only get what you can get sometimes. If there's something that's not allowing the donor to give that source of stem cells, and that's the donor that you have, it is not unheard of. It's not impossible. It's not wrong to basically use a peripheral blood stem cell source. But there's generally, I'd say, a preference for bone marrow in pediatrics.
Another question from the room, or?
Yeah, can you
Okay.
talk about cyclosporin and I guess some of the other immunosuppression drugs and I guess the success rate after ATG? You said we didn't want to talk about the patient, but we had issues with the kidneys with cyclosporin. So I guess the success on maybe a different drug or testing with other drugs or...
I think that we answer the question in the frame of essentially the balance of benefit and toxicity when you're on an agent chronically.
Right.
And I think that we tend to tolerate the toxicity that's expected in different parts of the body, including the kidneys, as long as it's manageable, as long as it's monitored properly, when we feel like there's some benefit that we can see of that agent. And when it's very short term, you can't judge it and you have to be patient. But when it's getting very long term and all you're seeing is toxicity and no benefit, then it's really a good time to ask, in my opinion, the question about what are we doing next, because it doesn't seem like this is working and we have other things that we still need to do, and are we just accruing toxicity at this point? Yeah. And that becomes a subtlety and you have to judge it carefully for each individual about, did we get anything out of it? There has to be like kind of this consensus. It worked, it didn't work, we still need to give it time to see if it works. That's kind of the category that you find yourself in as time goes on.
Beyond cyclosporin, have you guys tested or are you guys looking at any other immunosuppression drugs in pediatrics?
Yeah, so there are absolutely other immunosuppressive drugs in pediatrics that are used that are analogous to cyclosporin, especially in the context of transplant. So another drug called tacrolimus, but these are not the agents that have typically been used as an immunosuppressive therapy strategy for aplastic anemia. Yeah. And when other ones have been trialed, and I wouldn't say just the cousin or a slight modification of cyclosporin, when another whole other agent has been trialed, like a chemotherapeutic agent, like cyclophosphamide, or another powerful immunosuppressant, Campath, alemtuzumab, those have not been superior to this approach, to just using ATG. And so those types of studies have been done, sometimes not exclusively or in a targeted way in pediatrics, but those strategies, while they seemed attractive as alternate methods to immunosuppress for aplastic anemia, didn't win. They basically ended up being ATG, cyclosporin ended up still being the approach.
We've got two questions online. The first one says, we're in the process of receiving a diagnosis. There's been talk of aplastic anemia and ITP. Are these diagnoses similar? And if not, how do we decide which is correct?
That's a good question. And some people, so one thing that's very common in the diagnosis of aplastic anemia or bone marrow failure is to have had other diagnoses first, and for it to be a little bit of a process of checking back in before one arrives to the diagnosis. ITP and aplastic anemia should be distinguishable ultimately by the bone marrow exam. So that, I think it's pretty clear that one of them is a destruction problem, where you basically are destroying the platelets after they've come out. That's ITP. But the production of them is still trying to compensate. Like the production part has not actually quit. Whereas aplastic anemia would be that the platelets are low because we're not making platelets and we're not making as many red cells and we're not making as many neutrophils. So sometimes it's complicated, especially if that attack process on the platelets is also happening to other cell types, which can happen in other autoimmune diseases. but they are fundamentally different, and the bone marrow exam itself should be able to distinguish between those two.
Does someone have a question in the room? Okay, we'll go to our next question. This one is MDS, pediatric MDS and transplant. How do you know when to go to transplant and when to watch and wait?
So it's a good question also. I know there's been talk at the conference too, and in general, about how MDS is defined and classified, low risk, intermediate risk, high risk for adults, and there are classification systems used for pediatrics, but I'll say that it's different in a lot of ways too. So the way you define MDS is, let's say, at 3 levels. One is by looking at the cells and seeing that there are changes in the shape of the cells that would be categorized as dysplasia. A second way would be to look at the chromosomes and to see that there are chromosomal changes that are associated with MDS, such as loss of chromosome 7 in the blood cells, or 3 copies of chromosome 8 in the blood cells. And then finally, it can be that you see that there's lots of changes in the chromosomes, and that's called complex karyotype. And it's MDS and not cancer yet, because by definition, the other thing you're looking for is, are there a bunch of very, very, very early cells populating the bone marrow and perhaps pouring out into the peripheral blood? That'd be more like a leukemia. And there's numbers that dictate when it's considered just more blasts, these are called blasts, or when this is called leukemia. So presuming that there is some evidence of MDS at one of those levels, we will judge it very much based on what it is. Is it just that the cells look funny but the chromosomes are normal, or are the chromosomes starting to change differently in pediatrics? Because some of the inherited marrow failure disorders, they actually have typically some changes in the cell shape. And we tend not to judge those too heavily in terms of saying, oh, this is myelodysplastic syndrome, and this is the trigger for actually needing a stronger intervention. But we would take chromosomal abnormalities, generally speaking, as evidence of MDS and needing to basically be more aggressive. So that gets to the timing issue a little bit of, how are you defining the MDS? What are the changes that are occurring? And if they are significant enough, and one threshold for us being chromosomal abnormalities, what are your donor options? And what is your disease? What is the underlying disease that you have? So that's a bit of a complicated answer, but for instance, I think I'll give a couple of scenarios to just kind of quickly illustrate it. That if it's a patient who's known to have dyskeratosis congenita, and some of their cells look a little bit strange, but all of their chromosomes look fine, we will not change our management. That patient has marrow failure. But if you have a patient who has anything, even unknown, and all of a sudden the chromosomes are becoming monosomy 7, single copy of 7, that almost is basically triggering the person being considered heavily for transplant. There's one exception to that right now, in terms of thinking harder about it, and that's SAMD9L mutations as the underlying cause. But generally speaking, if a person has a single copy of chromosome 7, you are thinking, what is our transplant strategy going to be for this disorder?
Any questions in the room right now? Okay. Our next question online says, could you speak about the success rate of a haplotransplant from cord blood with very severe aplastic anemia?
That's a difficult one. And I think the scenario doesn't come up much, not to dodge around the question, is that why should it be cord blood? Because depending on the overall situation for the child.
It says it's banked cord blood, so it must be from a family member.
From a family member, right.
They're kind of
No, thank you.
bringing things in here, so yeah, it's a banked cord blood, so I'm assuming that's.
So I can't, to be honest with you, I can't really speak to the success rate of a banked haplo cord blood, because essentially in studies, that has not been the haplo source. So the advantage of the sibling cord blood has absolutely been used. But a haplo, one of the biggest advantages of it for a child is that their parent can be an ample donor of bone marrow, a preferred graft, and also with the same degree of match as a half-matched sibling. So I think that studies generally don't involve that source, and I would think hard about why one would feel like they needed to use this source. Now, things could come into play that the parent is unavailable, the parent is sick, they can't actually undergo the procedure, etc. And I wouldn't consider it then necessarily inferior. you may have to think a little bit about the conditioning regimen that you would use because it's an unusual source and degree of match. Interestingly, cord bloods are not easier to engraft, but are more tolerated in grafting across HLA disparities. So a 4 out of 6, imagine that like we're talking now out of 6 alleles for a reason, but if the sibling is 3 out of 6, 4 out of 6 unrelated donor cord bloods are used all the time. So it's not unfeasible. I think I would push back the question on why. Like, why are we using a limited graft source from a sibling at 3 out of 6 match where we can just use a bone marrow source from a parent, if possible.
Any questions from the room? Okay. I'll go to another one online. Can you speak to the standard of care treatment regimen post-BMT to decrease the risk of GVHD? Cyclosporine versus tacrolimus, methotrexate versus mycophenolate?
Mycophenolate, yeah.
Mycophenolate.
Okay, so after a bone marrow transplant, depending on so this is going to be another depending on, you can see it coming. Depending on the graft source and the way that the transplant was done and what regimen was used in the past, one will use certain agents to try to prevent this reaction of the graft as an immune attack on the recipient. That's standard. And so there will be a couple of agents typically that are used. The classic ones would be methotrexate, which is a chemotherapeutic, and cyclosporine. And tacrolimus is a similar, it's a different chemical, but similar, one can consider it similar to cyclosporine. It probably has slightly less renal effects, or it's a little bit debatable what it is, and hasn't been integrated into aplastic anemia as much, but it can be substituted, and now this is something that the adult practitioners use almost, I'd say exclusively, is tacrolimus, and it's finding its way down into pediatrics as an equivalent approach. So consider cyclosporine and tacrolimus equivalent, and then the standard in most regimens would be methotrexate. Depending again on a regimen and how you're doing it, you may actually end up using mycophenolate. So for instance, if methotrexate is more cytotoxic, you wouldn't want to use it in a cord blood transplant typically as much. You would. In certain inherited marrow failure disorders, we have actively avoided methotrexate because we felt like even that dose of chemotherapy, which is relatively low, could be hurting other parts of the body, and we preferred mycophenolate. So I'd say that calcineurin inhibitor, which is either cyclosporine or tacrolimus plus methotrexate, is still a standard in aplastic anemia, and there are reasons why you can substitute it out with mycophenolate. And then finally, all of that may change if you're using a graft source that's different than either of those two, like a haplo donor or a manipulated graft, meaning like you've taken the T cells out of the graft, and then those things can change after that.
Any questions from the room? No, we're good. Okay, we'll go to our next question online. And this question relates to mutations. Can mutations develop or change over time? And if so, how do you know when to be retested if there were nothing at the time of diagnosis?
Yeah. Also a great question, and it's cutting edge. So the answer is that we need to figure that out. Let's assume that the question that's being asked is about mutations other than a mutation that is one that's clearly associated with, first of all, being inherited and a bone marrow failure syndrome, and more about a question that says you have aplastic anemia or bone marrow failure, whether it's a germline cause or not, whether it's inherited or not, and you are getting a bone marrow exam. And on this day, because they're now available, even if we don't know exactly how to use them, we do that test of sequencing all those genes that are associated with MDS and AML, and you get a clean report that there's basically nothing that we can actually see in those. How should you use that test now in surveillance? So also, again, depending on what else is happening with the patient and their underlying diagnosis, it is actually unclear. It remains to be studied and known with what frequency and with what sensitivity that test is going to be useful in a pediatric population to track this clonal evolution. If people have done it, they probably will do it with the next marrow. It probably doesn't need to be the thing that drives the next marrow exam sooner, but it would probably be done with the next one that was done. And oftentimes marrows are checked yearly for an inherited marrow failure disorder, more often if you see a change in the peripheral blood counts. So there's not a standard for tracking clonal evolution in marrow failure disorders for the most part in children yet. and their utility and frequency and how you integrate them, it needs to be developed.
Okay, thank you. Any questions from the room? Okay. We'll do another one online. This one is in regarding pediatric PNH. At the time of diagnosis, my son was not diagnosed with having PNH clones. Successfully treated with ATG and cyclosporine and doing well. Should we be concerned about a future PNH, and is this something that we as a family should make sure he's being regularly tested for?
So in the scenario that you described, I would say no. I think that now, if the patient has been treated successfully in the absence of having the history of a PNH clone for aplastic anemia, now the surveillance is essentially their blood counts, and seeing that that response was durable and that they're doing okay. I wouldn't see any reason to start integrating PNH evaluation at that at a later stage at all.
Any questions from the room? The next one, I'll read one from online then. In terms of MDS, could you speak about trisomy 8?
Yes, so we talked about this a little bit before. So 3 copies of chromosome 8 can be associated with marrow changes that are reflective of MDS. And their prognostic significance, meaning like what they mean in terms of how much we're headed towards a higher grade MDS or an AML, is somewhere in between unknown and or not great and something like a single copy of chromosome 7. You wouldn't get much debate about that. And there's certain genetic mutations, germline genetic mutations, where you can see trisomy 8 pop up. And you'll still see some level of debate about whether or not, given all the other circumstances, that should be a trigger in and of itself to transplant. That standard has evolved over time. So I think it's, in a nutshell, you take it seriously, it would probably drive some degree of accelerated surveillance of the marrow. In an ideal circumstance, it might actually be the driver of going ahead and going to transplant in and of itself. In a non-ideal scenario where the donors are not great either, and depending on what if an underlying mutation could be found, it may be something that could be observed. So it's a bit complicated, but it is one that is one to take seriously and to watch.
Any questions from the room? Okay, we'll keep going on. This question is actually from a mom who is going to be the donor for their child. They'd like to know, what is your experience, and can you speak to the success rate of a parent being the donor for their child?
Yeah, so this would be probably, unless the genetics aligned in some way that sometimes happens, where the mom is a better than half match for the child. And again, in some unusual circumstances, sometimes it's better than that. But typically, I think what we're answering the question about is a haplo donor, haplo transplant from mom to a child for aplastic anemia. And I think the way to put that is that the success rates should be better now that certain regimens have been developed that allow success around that. And there's enough enthusiasm about that, especially from the adult world, about considering those to be moved to upfront therapy. Some of the major concerns with doing haplotransplants were transplanting across a larger HLA barrier, rejecting the graft or causing too much graft versus host disease. And the second part, at least, has been satisfied by very good studies that have been done in lots of patients now of using more chemotherapy after the transplant is given. And that's usually, that's called post-transplant cyclophosphamide. So if the patient can tolerate it, depending on what their underlying disease is, that has been successful and actually is looking very good. And again, enough enthusiasm to consider this should be a donor source or should be studied head-to-head, should be studied in relation. So part of it depends on whether they're in a clinical trial. Some of the success of it needs to be determined, but the data leading up to it says that this can be done successfully and safely.
Okay. Any questions from the room?
After a bone marrow transplant, what's the regimen after quote-unquote successful transplant, like for, I guess, life?
months and years to come, yeah. And this is what we counsel people about what the outlook should be, with lots of hedging, of course, as you've become quite familiar with over the course of the past hour or two, and probably over the course of your discussions with your doctors, because a lot of it depends on how things go. But let's post the ideal scenario, right, in terms of timelines, that once the decision is made to go to transplant, the donor is identified, in the few weeks that precede the transplant admission, the patient is evaluated, the donor is evaluated, the arrangements are made for admission. The admission happens, the patient gets whatever therapy they need to prepare them for the transplant, and then on day 0 is when they get the transplant, like a blood transfusion, like I told you. Usually there's going to be a period of time inpatient for about 30 days if things are going well, where you're being watched very carefully for the cells to come in and engraft. Doesn't have to be perfect, it can be mainly the neutrophils have to come in to see that there's some sign of engraftment. And then the other things, there'll be a lot of supportive care. What I tend to tell people is that the way to picture this is when you get discharged from the hospital, because you're eating enough perfectly? No. Eating enough? Sure. Your pain is controlled, your other organs are looking okay, you don't have infections. You go home and you need to come back to clinic about twice a week for monitoring your drug levels. You'll be going home on about 10 medicines compared to before. And the goal then in the big picture is from that 1 month period to about 1 year after, you have to protect yourself very, very carefully. But if you're successful and if the graft takes and everything goes well, a year later, you're pretty much off all of your medications and you're preparing to go back to normal social engagements in life. And the important thing to say about that is that there's no other type of transplant really where you have the expectation of being off all medications and going back to normal life. Any organ transplant is going to require you to be on some immunosuppression forever. What else happens in between are the things that you probably have already heard about. It's like, are there infections that cause problems? Is there graft versus host disease that cause problems? How did the graft do? Is it sticking? Is it doing well? And those are the things that change that entire timeline. But about a year, under promising a little bit, sometimes a little bit sooner, you can kind of get back to some of the business.
Go ahead. So our daughter was 2 at the time of transplant, and her donor was in her 20s. So is that lifespan of that bone marrow going to change for her when she was so young?
So just a really great question. That you got bone marrow from someone whose stem cells are older, and you're putting them in someone who's younger. What does it look like 30, 40 years down the road? I think the simplest way to answer that question is that that's a great age to be transplanted at, and that's a great age for a donor to be. And we have an expectation that there's nothing that's going to exhaust about that. There's going to be, we actually probably don't have data to say what happens 50 years later at this stage, right? In that type of scenario. So we don't really know what happens way down the road. But every level of confidence that should be just fine. Like basically that the cells that came in from a young donor are going to stick and do well.
We have a question from online. We'll go to that one.
That's great.
For a patient with aplastic anemia that has an increasing PNH clone, will the patient still need to be monitored for PNH after the transplant?
So that's also a good question. Let's put it this way. If the patient has had a successful transplant as defined by, and you can quantify this, that the donor cells are all the cells in the blood are all from the donor, and there's no real trace of the recipient there, I'm not sure that you would necessarily need to be monitoring for that afterwards, because that should go hand in hand with some problem with the graft actually sticking. Yeah.
Okay. Any other questions from the room? Okay. The question online is, and this is our last one online, that says, what is happening in the research now that makes you most excited for the future of pediatric aplastic anemia, MDS, PNH, and transplant?
Great question.
We have all day.
I think personally I'm most excited about being able to come up with ways to reduce the toxicity of transplant so that it becomes something that can be entertained earlier in the process of diagnosis. So in the case of up against, immunosuppressive therapy as a definitive therapy, earlier while worrying about MDS risk in patients who have inherited disorders. We're actively working on that. Dr. Pulsifer is actively working on that, trying to compare those outcomes. We will need innovation in how you actually prepare people for transplant, certainly, but I think that's what makes me probably most excited.
Dr. Pulsifer, if you were able to join us, do you
Oh,
want
sure.
to add anything, or?
I'm sorry, I was just rounding on my A-class anemia patient. And many others. I think
Is
the
this
only
picking, sorry, is this picking, I'm standing here because.
Yeah, we got it, so on the mic, thank you
The
so
mic's over
much.
here. I think that, boy, there are many exciting things going on. From a biological perspective, there are several new insights into both inherited marrow failure disorders and aplastic anemia, where we're kind of better able to understand why aplastic anemia occurs. And that's something that I hope will help us in the future. But for sure, the exciting things clinically right now are figuring out how to do transplants safer, how to decrease graft versus host disease, how to decrease some of the complications that occur, so that we can potentially do it earlier. We have to balance this because, when we get into some of the current approaches to transplant, we're affecting fertility. And one of the beautiful things about aplastic anemia transplantation is that most of the time they have completely normal fertility. But if a patient has failed a couple of therapies, if a patient has to have 2 transplants because they reject the first, if we have to do a haplotransplant and use higher doses of radiation, maybe we're going to affect fertility. And you'll hear more about that at 1 p.m. But there's lots of really exciting things that are going on. I think just in this past decade, we've completely changed the way we're treating aplastic anemia. So it's fun.
Any last questions?
So that would be my question. Do you have hope for the future? Like, I feel like aplastic anemia has about this much efforts going into it compared to like leukemia or cancer research, and just because it's so rare. So
Well,
do you have hope for these kids?
So I totally agree with you, and because of that, just to give you perspective, when I first started doing this, there were no pediatric trials, 0, and there was one adult trial that kind of lingered on and took 12 years to do, and on average, that's what was happening. Because of efforts that I've made, because of efforts that Suneet's made, because of efforts that Dave Williams and Akiko Shimomura made as we've established the North American Pediatric Aplastic Anemia Consortium, all of a sudden, in the past decade, now we have a phase 3 randomized trial. We have a new trial coming up that is looking at better approaches. We have Suneet's trial that he's shared with you. Whereas before there was nothing, now all of a sudden we have 3 to 4 active trials that are going on that are making a difference. So, and it's mainly because of people who really care about this. And so I agree, it's hard to get funding for it because it's such a rare disease, but thankfully we've been able to. So we're happy about that. So.
Okay, well, thank you both, Dr. Agarwal and Dr. Pulsifer, for joining us today. And there'll be more talk about aplastic anemia and transplant after we break for lunch with Dr. Pulsifer. So keep those questions coming. We'll be meeting again to continue the conversation at 1 p.m. Mountain Time. So thank you both for sharing your time and your expertise with all of us today. If anyone would like to watch the session again at a later time, it will be available on the conference platform within the next hour, and it will also be available on the AAMDS website in the next coming days next week. If you have any additional questions, please feel free to send it to us at any time in 3 ways. Send us an email to our help account, help@aamds.org. Give us a call at 800-747-2820. And if you are on social media, you can always submit your question to our Facebook page. If you're watching online, please take a few minutes to complete the session survey. Your input is very important to us and helps us plan for our future educational programming. Be sure to visit the exhibit hall, whether you're in person or online, and chat with our conference sponsors. We are getting ready to break for lunch, so we will be back online at 1 p.m. Mountain Time. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you for making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family as we've done for the past 40 years. This concludes our session.